Hey, good afternoon, everyone. We're going to go ahead and get started. It's 12:02, and we've got a great presentation to dig into today. My name is Mary Brandenburg. I'm the Director of Population Health with the VHHA Foundation, which is the philanthropic arm of the Virginia Hospital and Healthcare Association. We are so proud to partner with the Virginia Neonatal Perinatal Collaborative and other state partners on this webinar series that presents data that can provide insights into maternal and infant health outcomes. For today's session, our fourth in the series, we have a presentation from Dawnese Trumbo, Director of Reporting and Analytics at Virginia Health Information, or VHI. In her role, Dawnese oversees statewide administrative data collection and analysis programs and directs the organization's reporting strategies. With over 15 years of experience, she is skilled in strategic planning, business intelligence, and program management across various healthcare sectors, including delivery, human services, and insurance. Dawnese is dedicated to making impactful data accessible to decision makers and researchers, ultimately enhancing healthcare value and delivery. Before joining VHI, Dawnese served as the Director of Strategic Planning and Business Development at VCU Health System. She earned a Master of Public Health and Health Management and Policy from the University of Michigan and a Bachelor of Science in Business Marketing from Iowa State University. Beyond her professional commitments, Dawnese is an active member of her community, serving on the executive board of the Southside Community Development Housing Corporation. In this role, she strives to improve the mental and physical health of her Petersburg neighbors by promoting access to affordable housing and financial counseling. Thanks so much, Dawnese, for joining us today, and I will turn things over to you.
Thank you, Mary. Good afternoon, everyone. It is a pleasure to be here. Let me go ahead and get started here. All right, so agenda. Today's goal is three-pronged. We're going to talk to you all about Virginia Health Information, or VHI in general, kind of some of our history. And then we're going to dig more specifically into the all-payer claims database and some of those potential use cases. Then I will graciously hand it off to my colleagues, Marcus Stivers and Hannah Newsom, to talk to you all about the Emergency Department Care Coordination Program that we refer to as the EDCC a little later on in this presentation. All right, so to go ahead and get started, I believe many of you probably heard of VHI, but I'm going to give you all some history. So VHI got its start in 1993. We actually just celebrated our 30th anniversary last year as a public-private partnership that administers many of Virginia's healthcare data programs and initiatives. Many different types of stakeholders are on our board. As you can see in this little pie chart here, we have state stakeholders, business, consumer, health insurance, nursing, hospitals, and physicians that all make up the direction and give us that support for this organization. So I'm going to go ahead and move on. Okay, so here's a fancy word cloud just about the work that we do. So we administer statewide health information exchange programs like public health reporting, e-health exchange, and the Advanced Healthcare Directives Registry. We also administer a suite of administrative data collection and reporting programs like patient level data, the all-payer claims database, which we'll get into a little bit more later, emergency department severity reporting, and the annual licensure survey data program. So that's a lot, and that's not even the whole list. I just gave you a part of it. But a way to boil it down is really in three words, right? So collection, exchange, and distribution. We collect all of this data for the state of Virginia in different relevant areas. And then we also run an exchange, right? So we provide that needed data at the point of care. And then some of the programs also do some of the reporting, right? So if you go to our website, you can see some of the reports that we published, as well as working with our other stakeholders and researchers to provide actual data, extracts for them to do pertinent research that helps with, hopefully, quality of healthcare and the system of delivering care in this state. So quickly on how we add value, and I'll just call out here, the 2022 annual report is available on our website. However, the 2023 will be available soon, so you can go and download that and read more about us if you want to. But Really, it's four key ways that we see ourselves adding value in the state. One, we've been around for 30 years, right? So we have that deep local knowledge of data systems, of relevant policy, and we have these great relationships with our key stakeholders as well as our vendors and partners. So we are really able to efficiently do this data, this world of data. We can get it done hand in hand with various stakeholders, with various vendor partners that we work with in order to manage the large amounts of data that we collect on the regular. And then we call it last mile service, but we don't, we're willing to service these meaningful but maybe low margin or no margin projects that come about. We want to make sure that we are staying aligned in our mission with the work that we put out. So our model is really cost effective, and we're able to partner with many people to get really important research and task force and collaborate. Like, we're able to do all that. So it's fantastic. And the last piece here is just a strong reputation of the unbiased decision making, both political and industry specific. I like to say that we let data be the bad guy. At the end of the day, we are just providing you numbers that exist out there, and then you do with those numbers as you will. So just to give you an idea of the timeline, 1993, as I said, we were founded, and our first baby was that patient level data system. So we are collecting all the inpatient data for the state, and we collect that on a quarterly basis, and we are able to send that out to different people who, purchase that product. But then in 94, we also inherited our second oldest program, which is EPICS. And so you may be familiar with this. This is where the industry report comes in. This is for those who have certificate of public need. You'll see the annual licensure survey data. We collect that and report it out on an annual basis as well. And then in 2013 is when the all payer claims database was created. At this point, it was voluntary, but then in 2019, I just skipped one, but in 2019, it became mandatory for health plans to report in. And so that is something that we're going to be getting into here shortly. And what I skipped over was in 2017, which is when the Virginia Emergency Department Care Coordination program was established here. And those of you on this call may also have experience, already be participants, or be interested in joining that. Okay, so to do a deep dive in the Virginia All-Payer Claims Database. As I said, it was originally established in 2013, but it became mandatory in 2019. We have roughly 6 million lives represented in the claims data. And then we have billions, and I think at last count it was 15.6 billion or 15.6 terabytes worth of data that we have medical and pharmacy claims, including Medicare and Medicaid in our database. And then the last point here, we are able to generate like hundreds of reports. We do this annually. We work with different researchers, health plans, and health systems in order to generate whether it's data extracts or reports to support healthcare reforms. So for scope, the health insurance companies that we currently have participating are all listed over here on the left-hand side. And just to kind of give you a breakdown of what that is, we have 100% of those fee-for-service Medicare claims. We have 100% of Medicaid fee-for-service and managed care individuals included in that database. And we, depending on the year, was roughly 45 to 60% of commercially insured individuals are included, kind of depending on whatever that time frame is you're looking at. The more recent, the higher level of commercially insured individuals that'll be included. And then just in case any of you are interested in using this as a potential data source, we'll talk about the process you access it. But I don't want to let you know that we do have data available from January 2016 through December of 2022 currently. And then by the end of this year, we'll have 2023 available. Okay, so it's fantastic. And I know it has the word all in it, but there are some populations that are not included in the APCD, and that is going to be the federal employees, the TRICARE active duty, and then of course the uninsured, right? There's no way to see them because this is claims data. And then a majority of the RISA self-insured plans also aren't required to submit. We have some of them in there, but the majority are not included. So put that as your caveat. So let's talk about what's on a claim. So when you're thinking about like, oh, I want to do this research or I want to pull this data to look at it, here are some of the like basic elements that are included. There's a lot more that are in there, but we'll have like kind of use the who, what, when, where, and why pieces here. We have patient demographics, right? So you'll be able to see the zip code of patients. You won't have patient name or any like PHI or PII, but you can have zip code, county, health planning district, age and gender. You can see different care details. We have procedure codes all the way 1 through 10. We have drug names that are included in there, the DRGs, the total allowed cost, and the total paid, which are both going to be proxy values to, not ruin any competitive information and share any of that between the health plans and the negotiated rates with their providers. And then for the where, we have for the provider and the payers, we have the billing provider, where they are, we have the service provider, we have the attributed primary care provider that's all included on the claims. And then we also have health plan names and kind of the health plan groups, right? So you either commercial, Medicare, Medicaid, et cetera. And then for the when, we have 2 dates that we really recommend people use, which is either going to be the incurred date, that's when the service took place, or the paid date, when that claim was actually paid. And the last piece here is the why, right? So we're going to have those diagnosis codes, CPTs, E-codes, and you'll be able to see the admission status for inpatients. So I've kind of been sprinkling these factors throughout the conversation, but for advantages, of course, this is great for any outpatient information because there really isn't a good source of that right now outside of, maybe your own that you have for your facility. But we have outpatient information, we have emergency room information, and we have pharmacy data all included in one. It's a great data source for commercial Medicare and Medicaid to see that all together. And it's based on actual reimbursement amounts. So you're able to see that even via proxy. And then we also make sure we include all the provider types. So that gives you some extra information. But we want to keep in mind these limitations, which is it won't be the entire state population. It'll just be those who are covered under the insurance within the APCD. Those encounters are going to be segmented. So if someone comes in for an inpatient visit, you'll have the pharmacy that the drugs they receive that as kind of its separate line item, as well as the different services they receive during their inpatient stay. So you'll get claims, but it'll have to be some work done on your end in order to combine them. And then, like I said, for reimbursements, we have those rates, but they're in proxy. So you have an idea of what an area would be reimbursed for a service. And then it's always going to be subject to the quality of the original submissions. So we receive these submissions directly from the health plans and then work with our vendor in order to process them and put them together into one large database. So, if it's garbage in, it's garbage out. But most of the time, we're doing pretty good. We're doing really well with keeping the quality up on these. So it's a really good data source, like I said, for a lot of reasons. It's kind of like what do you call those all-purpose knife things? I can't think of the word, where they have like clippers and all that. But that's how I see it. Like, okay, so. Now, for the APCD for maternal and child use cases, we have different options, right? So amazing research and analysis resources, right? So if an individual is included, we have a person key that spans from 2013 all the way through 2022. If someone is on an if someone is on a insurance plan and they go to Medicaid or they go to a different one, you can actually trace longitudinally their experience throughout over those years, because we have put in now I feel like I'm thrown off. We put in a key so you're able to look at people over long term. Then we're able to link those claims. So for example, if you want to look at COVID, right? So if you want to look at 2020 claims, you have 2016 to 2019 to give you kind of that pre-COVID time. And then you can look at 2021 through 2022 to get kind of a post. That's like one of the examples that we are working with some researchers on. And then the APCD can also help to answer a wide variety of like relevant questions. For example, down here, how did patterns in care vary for individuals with the desired versus undesirable outcome? And then how much in downstream healthcare costs did proper preventative care save? So these are just some of the examples that you can use with the APCD, but I'm happy to talk more with anyone who is actually, interested. You can see more information on vhi.org/APCD. And one thing to keep in mind is APCD is actually regulated through the legislature. So there is an external review process, like requests have to go through a data release committee, but we work with you hand in hand in order to make your request as strong as possible to get through. So with that, I'm going to turn over to my colleagues, Marcus Stivers and Hannah Newsome, to take you through the EDCC program.
Awesome. Thanks for that. So my name is Marcus Divers, and then Hannah, you give an introduction.
Yes, my name is Hannah Maddie. Sorry, Newsome is my maiden name, but either one is fine. Yeah, I am the community engagement specialist for Virginia Health Information. So sorry, that threw me off too. Donnies, you did great though. So way to work through that. Before I think we really dive into EDCC, do we want to pause and ask if anyone has any questions about APCD or the other programs that VHI offers?
Good call, Hannah. No, we have chats. Let me see here. Yep. Nope. Okay. Hearing none. We're going to go ahead and keep going. We'll also keep some time at the end. So any you can ask questions if you want to.
Great. Thank you, Johnny. So I'll go ahead and start it off, and then I'll hand it over to Marcus. So we're going to dive into VHI's Emergency Department Care Coordination Program, the EDCC. And this program was put into legislation in 2017, and it connects hospital emergency departments across the state with what we call downstream providers, which would include primary care, community service boards, free clinics, anybody who is not sort of on the hospital side is what we would really consider downstream. So its initial intention was to reduce unnecessary emergency room visits. So by facilitating that real-time communication between hospital emergency departments and downstream providers, we hope to enable these downstream providers to intervene with their patient populations before they continue to show up in hospital emergency departments. And Donnie, so you can go to the next slide. So basically how this works is the Emergency Department Care Coordination Program is required for all hospital systems in the state of Virginia to participate in this. And they provide us with what's called the admission, discharge, and transfer fee. So we use patient matching technology to enable a patient notification system and the care collaboration between the hospital emergency department and the care provider. So a patient shows up in a hospital ED. As soon as their information is entered into the hospital system, whoever and the downstream space that they are on that patient roster would receive an immediate real-time notification. And that provider can then log into their patient portal and see why they're in the hospital emergency department, what's going on with them, and the different ways in which that they might be able to respond to this notification so that they can prevent further ED visits. So what's really cool about the EDCC is that it's not just this event notification system. So if I work at a clinic and my patient shows up in the hospital ED, not only will I see in real time that my patient has been admitted to the hospital, but within my patient's portal, I also have access to care team visibility. So if I work in an OB's office and I need to contact my patient's psychiatrist, I'll be able to see who the other care team members are that have and share that active treatment relationship with my patient so that we can bring everybody together and address all of the different facets of patient care. So a lot of times what we see, Dawnese, was doing a really amazing job of explaining our data program sets and how that coordinates with maternal and infant care. And a lot of times what we see is people will use those data sets to identify what the problem is, right? What's going on with our moms? What's going on with the babies? How is everything affecting maternal health? What problems are pregnant women experiencing? What problems are they running into in childbirth? And so once we identify those problems using those data sets, then we look at the EDCC as sort of the solution. So who do we bring in? How do we provide that wraparound care for our patients and make sure that we're taking care of these mothers and babies on all levels? Because we talk about this all the time, right? Healthcare is not just about physical health. It's about social determinants of health. It's about your mental health, the behavioral health. It's about all of these different factors. So coordination of care is vital in providing the best quality care that we can for our patients, right? You can go to the next slide, Donnies. So when we talk about how specifically EDCC really works across this care continuum for our patients, you can see here that it enables us to follow the mom's journey, right? We confirm this pregnancy. A lot of times also when we see, it's really big in like the SUD space or mental health space, sometimes these moms are not receiving consistent prenatal care. And so they will show up in the emergency department for the care that they need. So when we have this event notification system and we're able to see everyone that's on this active treatment relationship with this patient, it enables us to better follow her journey and proactively reach out to these moms and make sure that they are getting everything that they need, the resources that they need. Are they experiencing, housing insecurity? Do they need help with refilling their prescriptions? Do they need food stamps? Why do they continue to show up into the hospital emergency department, and how can we help them and keep them out of the ED by providing them these resources and these services that they need before they keep showing up in our hospital systems, right? You can go to the next one. And so this, like I said, the EDCC serves as an event notification system and a care collaboration platform. These are some of the things that you would be able to customize your notification systems around what your organization would like to receive notifications on for your patient population. So these are just a couple of the different ways that your organization can receive a notification. Let's say you have a crisis team that you work with. You can choose to have a cell phone, a text message. When your patients show up in the hospital emergency department, you can choose to have a text message sent to your crisis team, who can then show up to the hospital emergency department and provide those services to your patients. Some people choose to have a specific email inbox where, their workflow is they get to work in the morning and they check the email inbox and say, okay, which one of our patients showed up to the emergency department last night? And they can go through and proactively contact those patients that they know have been admitted the night before or the weekend before if they choose to, check it Monday morning. So it's really customizable. Whatever works for your organization, your patient population, and your workflow, which is really important because we know that when we're taking care of a patient, that it's a whole person and it's going to be different for everybody, different aspects of their care and different teams, right? Like, what is this team's focus? What does that team do? What about this organization over here? That's part of that broader care collaboration piece that we know is so important to really take care of the whole patient, right? So I'm going to pause for a second and just see if there are any questions so far before I hand it off to Marcus.
Doesn't look like I see any in the chat. So I'll go ahead and kind of finish out the presentation on the EDCC. So from what Hannah was talking about and sharing earlier, you saw those lists of different diagnoses related to maternal health, whether that's your pregnancy diagnosis, labor and delivery, or diabetes in pregnancy, hypertension in pregnancy. These different conditions that you might have specific teams that want to focus on or do outreach for. Those are what we call cohorts. And kind of like has been sharing, the EDCC is really designed for you to customize and figure out the patient populations that you want to serve and enable your team to do that. And so what you see on your screen here, this is just a quick screenshot of what that would look like for if your organization was participating in. You could actually go in and dive into these cohorts of patients and see specifically, hey, how many of my patients that are pregnant and dealing or have hypertension are going to the emergency department this past week or this past month, and do your targeted outreach. You can also pull down specific reports. So if, let's say you don't have the resources to act in real time, or show up at the emergency department, again, you can use this information, pull reports, and compare this to other data elements that you might have. And then on the next slide, here's a couple examples. Kind of like to Hannah's point, we do have some health plans participating, hospital systems, and we call downstream providers, but a lot of the Medicaid MCOs use these features and reports a ton to help them do this targeted outreach, whether that's reaching out right post-birth of it to see what kind of resources or help that the health plan can actually offer to that patient and get them connected to some of their community resources. Or like I said, monitoring in real time and seeing how often their patients are actually using the emergency department and see if they can get them to better places of care than going to the ED. I think if we go next slide, this is an example of what we can also look at on a statewide level using what Hannah was referring to, those admission, discharge, and transfer feeds, or those ADT feeds from the hospital emergency department. We can actually use that information to monitor those same similar cohorts over time for the state. So we work really closely with DMAS at the state level and the Virginia Department of Health to kind of look at this information. But here's just one example of what one of those reports might look like. You can also work to pull something similar for your organization. And then we can go down to slide 25, actually. And so that's kind of all we have on the EDCC program. And just kind of wrap it up, Donnie's talked a lot about our data services programs or databases that you can access and do some analysis on statewide or your specific population or region. The EDCC program is really more for those care coordination services, those in the clinical space. So that's kind of all I had for the EDCC program.
Thanks so much, Marcus, Hannah, and Donice for sharing that information about what VHI can offer. I don't see any questions in the chat, but I have a question. So I'm wondering for Marcus and Hannah, if you could talk a little bit more about how organizations can plug into the EDCC. what the pathway is to that? Is there an associated cost? And also, do you have data that's publicly available for folks who conduct research or want to understand patterns of utilization at the state level?
Awesome. I can go ahead and take it in, Hannah, if you want to add something. But onboarding to the EDCC is really easy. I think we had our email on there, but edccsupport@vhi.org. You can email us. We have a couple of different groups, as you can imagine. There's different features available to health plans and hospitals and downstream providers. But for downstream providers, so your specialty clinics, primary care clinics, community service boards, federally qualified health centers, typically there's no cost associated with onboarding to the EDCC. And again, this is a program that's statewide. So if you're operating in Virginia, you have that. Really, the Hannah was saying that we only share information with organizations that share a treatment, payment, or healthcare operations relationship with the patient. So basically what that means is we'll actually have to work with you to get what we call a patient eligibility file or a roster file of your patients that you have that active relationship with. And we actually match that up with what we get in the ADT feed. So we know exactly who your patients are and who to kind of display and work with you on. I mean, as far as the research purposes, right now there's no, as far as the EDCC goes of those ADT feeds, there is no database that we put this in for public research purposes. The best way would be to sign up as an organization and you can pull those reports to kind of use in your quality improvement work. But we can work with you if you have questions at a statewide level to try to use those ADT feeds. But for the research purposes, that's why Donnie's and the data services team, they have a lot of those resources that are a little bit better for research.
Marcus, and I was also wondering if you could talk, I'm thinking about questions that have come up in other forums that people may be shy to ask. And so could you talk a little bit about sensitive service types? I know that you partner with community services boards with the EDCC program, and there's been good feedback from those entities about their patient populations and how they follow folks. So how do you deal with, for example, a psychiatric admission or something that may be considered more sensitive?
So for those working with those like SUD or 42 CFR covered services, like I mentioned, we work really closely with a lot of community service boards. We probably have about 20 participating in the state. And what we can do is basically when you're signing up, we could actually work with you in your roster, and basically we have a consent functionality to where basically on your file we could have a consent enabled portal, which basically means as you guys get your consent forms that allow for data sharing of these 42 CFR covered services to take place, we can take that from that file and let you share out that information to the rest of the network. But if not, let's say if someone hasn't consented to share that sensitive information, we'll actually just restrict it to where no other organization can see your association or your work with that patient. But you would still have access to those ADT alerts being from their emergency department that just fall under different restrictions than others. And again, if you're following the space, the 42 CFR and these sensitive service rules are and especially in the health information exchange are always changing, and we're always doing our best to keep up with that and make sure that we can getting the right information that we can to the providers.
Thank you so much. I really appreciate that. That's super helpful when we're thinking about the causes of maternal mortality in Virginia, the relationship between mortality and substance use disorder and mental and behavioral health. So I appreciate you clarifying that for sure. I was also wondering if you wouldn't mind, just for folks who are more chat savvy than I, dropping a link perhaps to your website in the chat, just so people have it. I know we'll have this recording posted on the VNPC YouTube channel, so it is free and publicly available. If folks who are on the call today have colleagues who would like to check in or review the materials, but just in case, if folks want to do a quick copy paste or link, the organization's URL is in the chat. So thanks, Marcus. I appreciate that. Or Donnie, sorry. Thank you.
Awesome.
And I'll just pause here for any last minute questions or comments. I don't see anything else in the chat, but checking in with you, Donnice, Hannah, and Marcus. Anything else that you would like to share?
I think overall is feel free to reach out to us if you have a data need. If we can answer it, we can probably point you in the right direction of who can and where you can go to. Or if you have something like really innovative that you want to do, we are always down for that too. So thank you all for your time and attention this afternoon.
Thanks, everyone. Just FYI, our